All right. Welcome everyone to the Health for the World International Grand Rounds. We are really honored to have our International Grand Rounds speaker today, Dr. Jeffrey Dayton. And Dr. Dayton has an extensive experience in interventional radiology. As you can see on the slide, he has a 30-year IR career and can share with us really useful tips today. Dr. Dayton worked at Kaiser from 1987 to 2016 for 29 years, and was also the chief of radiology for 10 years during the time at Kaiser. He trained at UC Irvine, did his fellowship in IR, he did his residency at UCSF, and his medicine degree from Hahnemann University School of Medicine. Dr. Dayton also has interest in global health and has traveled internationally to help with education in IR, and was recently in Kenya. So thank you so much, Jeff, for giving this grand rounds for us, and you can start whenever you're ready.
Thank you, Bhavya. Welcome, everyone. I hope you're safe in this crazy times. Let's take a little pause from that and talk a little bit about interventional radiology from my perspective. As Bhavya said, I started doing this in the 80s when interventional radiology was kind of new, and things were changing rapidly. And I'm going to move the slide along here a bit. Oh, there we go. So, innovate but validate. As the slide says, interventional radiology has been a disruptive technology in medicine since its beginning. And by virtue of that, it's kind of impossible to know as you do it what you're doing in terms of effectiveness and risk. So we forged ahead and I think did a lot of great things. But after you've done it for a while, it's important to look back and see, well, did that turn out to be true? Is angioplasty actually better than surgical bypass? And so you need to do studies to validate what you've been doing all these years. So that's the main thrust of the talk is let's forge ahead, let's continue to innovate, let's continue to create new ways to make things either more healthy or less invasive or less costly or some combination thereof. And at the same time say, well, let's study this, and because a lot of the things we did, or some of the things we did, as I'll show, did not turn out to be the best way to do it. So I'm just going to briefly run through some fun stuff. As Bhavya said, I got my training at several different University of California institutions. Then I went to Philadelphia for my medical education. Then I came back to San Francisco for my internship and residency. And then I went down to Southern California for a fellowship in interventional radiology. Then I joined Kaiser in 1987 and worked there for my entire career, which is a little bit unusual, but turned out to be a very good job for me. And this is our new building. About 5 years ago it was built and moved in there. This is one of our procedure rooms in the old hospital. And just to let you know where Oakland is, where I practiced, here's a map of the United States. And whoops, over there on the far left is California. And within California, the right slide, Oakland is a little bit east of San Francisco. And if anybody is a basketball fan, this is the team that is given us a little bit of glory most recently. With several world championships in basketball, and you may know Steph Curry. So my bits of advice for a successful IR career and practice is the subject of today's talk, Innovate but Validate, but also, and I won't talk about these today, but I think they're important to remember, is to have an active QA program, because not only do you want to look at your practice for procedures, you want to do it on a minute by minute and day by day basis to make sure your practice is safe. And finally, especially in the United States, physician wellness is a big issue now because there's a high rate of burnout as physicians are more and more disillusioned. And so there are strategies to help you survive the stresses of a medical career. I'm going to give you a very slanted and brief history of IR. I trained kind of in the beginning. It started actually in the 70s, and some of the early procedures were in the 60s, but it really blew up in the 80s with more and more procedures. Much of what we did was diagnostic angiography, and it was before we started actually intervening. So some of it, and these were offshoots of diagnostic angiography, and so this was the chairman at UCSF when I was practicing, Alexander Margulis, and he was not an interventional radiologist, but he did coin the term. And he established one of the best radiology departments, if not the best in the world. At least that's our perspective. And there's a fundraiser every other year, and this is my wife, and they raise money, the Margulis Society, for resident education. And these are some of my mentors. Ernie Ring is a famous interventional radiologist and developed some of the early things. And these are a few others: Bob Curlin, Mike Dake, and Barry Katzen. In 1987, when I started, femoral popliteal bypass grafts were the mainstay for occlusive disease of the superficial femoral artery and other adjacent arteries. Now, those are rarely done for that, and it's done with angioplasty and stenting. Filters were placed by cut down, usually by vascular surgeons, and it was a mess. Lots and lots of blood, big hole in the vein. Now they're put through little punctures, and just a very fast, easy procedure. Diagnostic angiography was done with a catheter and using cut film and taking many, many minutes to run those in a processor. Now it's done without a catheter at all. It's just done through an IV and with CT angiography and MR angiography. Fibroids were treated almost exclusively with hysterectomy. Now there are a plethora of ways to treat them, but among them, and this has been validated with really good literature, uterine fibroid embolization, something we do. Portal hypertension, very invasive, very morbid procedures, surgical procedures, including portocable and mesocaval shunts. Now it's done with tips. Hepatocellular carcinoma, didn't have a lot of treatment options. Now there's many, interventional oncology is a huge field now, and there are many options to treat that. Vascular access devices were almost exclusively put in by surgeons in the operating room. Now we place ports and other such. So there's costs. I always like to consider costs in the evaluation of procedures, and in the United States, it's a big problem. Industry is responsible for some of this, physician practice, and it's a complicated issue, but just to give you an idea of what things cost here, it's in 2018, when we have the last reliable data, $3.6 trillion were spent on healthcare in the United States, over $11,000 per person, and the next closest country is way far behind, and that being Switzerland. And despite that, our health outcomes are not all that great when you compare to a lot of other developed countries in the world. So I work for Kaiser Permanente. It's a different system than a lot of systems in the United States, at least then. And it is what's called a capitated system, where you pay a certain amount, or your employer pays a certain amount of insurance, and you get comprehensive coverage rather than paying as fee for service for each procedure or visit. You pay a fee. That's not the way it works with Kaiser. But even in Kaiser, costs are out of control. So now I'm going to shift a little bit to IR specifically. And this is my personal list of criteria of features for an optimal or good interventional radiology procedure. In the ideal situation, it would have a high technical success rate, would have a low complication rate and rate of side effects. It would be inexpensive. Other treatment options would be more costly or more invasive. It would be curative. It would treat a common condition. ideally treat a benign disease. And if it's palliating, then it should offer symptom relief and extension of life. Using these criteria, two of my favorite procedures are, believe it or not, very simple ones. Placing a catheter to drain an abscess. It's quick, it works, it's safe, and patients recover completely, and you're done. And it's very satisfying. Embolization of acute hemorrhage is another example. People are in life-threatening situation. They come in and it may be very inaccessible surgically. And even if it is, we can embolize less invasively, and it can be a fast procedure. And if it's done, depending on the cause, can be the single procedure. So before we look at where we're going, now's the whole validate part of the talk. We're going to look back and see what we were doing, and of those things we did back in the 80s and 90s and 2000s, which of them turned out to be effective and satisfy most of those criteria, and which didn't. So by virtue of where I was specifically, because Kaiser has multiple hospitals in Northern California and a catchment of about, at the time, 3 million, now it's about 4 million patients. We started doing some of these things for the whole region before interventional radiologists were in all the hospitals. This includes TIPS. I hired as my second partner, there are now 6 or 7 in our department, but I was the only one in the 80s. And in 1993, I hired a partner who had done over 100 TIPS procedures at UCSF, training under Ernie Ring. And so we became the regional center for TIPS. And then also we became a core site for uterine fibroid embolization, reporting to the National Registry. Vertebroplasty, similarly, we hired a third partner who became the regional expert in that, and we all did a lot of vertebroplasty and kyphoplasty. So here's an example of what I think we did right. I need to move something. Hang on one second. Balloon angioplasty and stents for treating occlusive disease of the arteries. These virtually replace bypass surgery and in most settings, and revolutionize the care of occlusive disease of the lower extremities, the kidneys, etc. Thrombolysis, whether mechanical or using drugs, extracting clot or dissolving clot from arteries and veins throughout the body. As I mentioned earlier, embolization of acute hemorrhage, placement of permanent IVC filters, and I'll talk a bit about in a few minutes about retrievable or temporary filters. TIPS, which are transjugular intrahepatic portosystemic shunts. We place many of them, mostly for bleeding esophageal varices. Excuse me. Nowadays, things have refined a little bit, where the initial preferred treatment is medical, but we still do plenty of those for that. And it's a preferred treatment option for refractory ascites and some other conditions. Uterine fibroid embolization has been well validated with really good registry studies throughout not only the United States, but Europe. And it is less invasive, and it's not 100% curative, but it has a high cure rate for treatment of fibroids. Another example is management of hemodialysis access. We use angioplasty, thrombolysis, stents, thrombectomy to maintain these access for end-stage renal disease patients and keep them on hemodialysis and keep them alive longer. And then here's some other non-vascular procedures such as nephrostomy placements, ureteral stents, biliary work, drainage of abscess, drainage of fluid from the chest, from the abdomen, from the pericardium, cyst, etc. Another really big example that revolutionized the care of abdominal aortic aneurysms is placement of endovascular grafts, stent grafts. And here's another list of vascular access placements, doing needle biopsy, embolization of varicoceles, and ablation of osteoid osteomas. Also, this isn't a procedure, but we, in the 1990s, I believe it was, started doing clinical care. You know, in the past, interventional radiologists were just a service. You checked a box and wrote an order. Oh, send this patient off for an angiogram or a procedure. And we saw them, and then we said goodbye after the procedure, and that was that. Partly due to political and partly due to financial pressures, the societies decided we need to have a more strong clinical presence. So with time we did, and we started rounding on our patients. We saw patients in clinic. We hired physician extenders to see patients and have a more sustained and direct care path with these patients. And as a result, with our advice on, say, management of a catheter we've placed in somebody on an indwelling basis, the patient gets taken care of better. We manage when we speed up the process by managing the use of the catheter and when we remove it. Now I'm going to shift gears to some things where maybe our early enthusiasm wasn't well warranted. And one example is the use of vertebroplasty or kyphoplasty to place cement into benign osteoporotic compression fractures of the spine. As I said, we were the regional center for Kaiser for years of this until it emigrated out into the rest of our hospitals, and did hundreds and hundreds of these things with the thinking that we were reducing pain in these women, primarily women, with osteoporosis. Now, there are a number of indications for vertebroplasty and kyphoplasty, only one of which is, but the most common, is for benign osteoporotic compression fractures. We also do a lot of spine surgery, pre-op and post-op stabilization, and those indications are still valid. But there were 2 studies published in the New England Journal of Medicine in 2009 using sham procedures, and these people were randomized into you got needles placed in your back or you got needles placed in your back and cement injected. And it turned out that in about 6 months, the patients did the same, whether they got cement or not. Now, there were some flaws in the design of the study that were criticized roundly, primarily by people doing a lot of them and by the industry representatives that made money from them. So another study was published in the British Medical Journal that addressed most of these and also concluded the same thing. So, this study has also been criticized despite that for the same reasons. However, the point is at a certain number of months after compression fracture, they heal. And the amount of pain one has at 6 months is unchanged whether you get a vertebroplasty or not. So really the question is, how bad is the pain? Is it life-threatening? And there are definitely selective cases when vertebroplasty will be beneficial and shorten the time of that pain. And there are also other indications, malignant ones, and like I said, spinal pre and post-op stabilization. But for the routine patients with moderate pain, it's better to actually wait and not do this invasive procedure. So as I said, we did hundreds of these. We didn't challenge the assumption. We just blindly went along assuming we were doing great care. And the studies done on them weren't really designed the way these critical studies were. They were just said, how safe are they? What's the complication rate? This seems to be reasonable, and these people are getting better, so we must be doing good. Well, turns out not so much. So how much time did we waste? How much money did we waste? Here's another one. This was quite controversial even as it was coming out, and it was basically the use of angioplasty to treat the jugular veins and other central venous veins of draining the brain in patients with multiple sclerosis. And CCSVI was coined by Dr. Zamboni, who observed that cerebral venous stenoses were present in many of his multiple sclerosis patients. And the theory was that this resulted in elevated intracerebral venous pressure, and that by relieving this, that might liberate the patients and improve their MS status. And it turned out not to be true, and a study done and published in 2017 concluded venous angioplasty cannot be recommended in patients with multiple sclerosis. Another example is temporary IVC filters. The problem with the design with temporary filters is there's a paradox. They need to be secure in the vein, but they also need to be not secure, in other words, retrievable from the inferior vena cava. And it's a major source of litigation. If you were to put Google IVC filters in the United States, you'd see all kinds of ads by lawyers willing to represent those patients for the harm that these have done. And these include leg penetration through the caval wall and therefore into other adjacent structures such as the aorta and duodenum, fracture of the legs, tilt, thrombosis of the cava, dislodgement, floating up into the right ventricle, etc. And so the problem is easily solved and has been since then with registries, but it unfortunately isn't done in all cases. Once the indication for the filter has passed, you need to go back there quickly and retrieve them when they are most retrievable before all these complications occur. Or if it's somebody who might benefit from a filter permanently, or is advanced in age or has severe disease, don't worry about a temporary filter. Place one of the proven permanent filters that are really good and just leave it and don't worry about it, because they don't have these same problems. Here's one of those ads about temporary filters. And then here's another one. So there are a lot of lawyers willing to represent these patients. Renal angioplasty for hypertension has not proven to be effective. And then here's some other ones. We did a lot of percutaneous, and still do, gastrostomies, but the widespread use of them for a lot of stroke patients, and especially patients with dementia, really don't benefit most of these patients, and they do better with spoon feeding, but there are definitely still indications. And questionable, placing PICCs in little tiny veins in kids can cause arm thrombosis. Sclerotherapy for AVMs has got a narrow risk-benefit ratio. Atherectomy, and then some of these others haven't really turned out to be as great as we thought and as promoted by the industry representatives. So what are we doing now that will be validated in the future? And maybe let's look at some of the future things, and conversely, what will maybe turn out not to be so good. And this is actually the main point, because we know what we didn't do well in the past, but what we're doing now, we need to think a little bit more prospectively and have a bit of a skeptical eye and actually validate what we're doing with effective studies and prove that they're effective. So this is something in present and future, stroke thrombectomy. I happen to think this is one of the best things that we could expand in the United States and worldwide. The problem is there aren't enough people doing them. It's an extremely common and if treated properly, a benign disease. And if we were to expand this greatly, we would have a huge impact on the morbidity and mortality of the population. Prostate arterial embolization is not quite ready in terms of proof, but it has a lot of potential benefit, is less invasive than some other treatments for benign prostatism, and is a little bit similar to fibroid embolization and in the concept and anatomy. So a little more complicated anatomy than the uterine artery, and it takes a little longer training, but I have optimism that this will be proven. Pelvic congestion syndrome, similar, embolizing gonadal veins in women. Radial artery access is still being studied, but has largely been validated as safe and actually is a preferred access rather than the femoral for many arteries. And there are a variety of ways to deal with pain. through interventional management. So I want to pause a little bit and just talk about interventional oncology. This is very big area of growth in the United States, and it has some problems in my mind that we need to take a jaundiced eye to as we look forward. It's being driven by industry. It's generating a lot of income for a lot of hospitals and insurance companies. Sorry, not insurance companies. It has few of my features of a high value procedure. It's expensive, treats malignant disease, and the gains are measured in weeks or months of life extension. And so what could that money be used for conversely if we have a limited amount of healthcare resources? The problem is there are many procedures, and the literature is not conclusive on this because the design of the studies that are published don't follow any standard protocols. There's a wide variety in design and what is measured, and it's really hard to compare all the treatments for hepatocellular carcinoma and choose which one you want to do on a particular patient. So, for example, chemoembolization, various ablative procedures, Y90, injection of ethanol, immunotherapy, chemotherapy, and combinations of all those. So, and then there are among those within chemoembolization, which embolic do you use and which agent, which chemotherapeutic agent, what is the treatment timing, how selective do you get with your catheter, how complete do you make stasis before you stop the procedure with ablation, what energy method do you use among them? With Y90, there are several questions of the specifics of the procedure as well. And similarly with injecting alcohol, what treatment modes? Similarly, as I alluded to, when you evaluate the results in the literature, it's hard to follow and make some conclusions. How is the response measured? Is that by tumor diameter, tumor volume change, the number of the tumors, the progression of the progression-free disease, the disease-free survival, overall survival, etc. What are the goals? Are you prolonging life? How much? You trying to just keep the patient going until some other things going? This is valid. A bridge to liver transplantation, this is valid. Making money, or just doing something. And there are costs to interventional oncology: financial, time lost to treatment, time lost to recovery from side effects, pain endured during the treatment, and dealing with complications. So I'm hopeful that this complicated mess will eventually lead through some good studies to some definite protocols to choose which are the treatments in various situations. In the meantime, it's going to be challenging and confusing and expensive. Okay, what else? What might we be doing wrong now? Endovascular treatment of acute lower DVT, lower extremity DVT, hasn't been shown to be as great as we'd hoped. And that was proved by the ATTRACT trial, which showed no difference in the rate of post-thrombotic syndrome after treatment. And with chronic lower extremity DVT, we need to know, will these stents remain patent in time? And those studies are ongoing. Drug-coated balloons and stents, primarily with paclitaxel, have been called into question recently by a study by Katsanos in 2018. This is very controversial, but he noticed in meta-analysis that patients treated with these balloons coated with paclitaxel or stents impregnated with them had a higher death rate. And there's no real known reason why that would occur. And many people think it's not a causative effect, but it is an association, and we're still looking at it. Also, the improvement in patency with these balloons and stents is marginal so far, and it adds cost to the procedure, both the using the balloons or the stents. And these are just some of the details of those. stent grafts when we're treating dialysis fistulae. Mostly we use balloons, but we salvage cases using stent grafts. They look very beautiful after you place them, but the patency is questionable as in terms of whether it's an improvement in just repeating stenting. I think that this might turn out to be useful, but we don't know yet. It hasn't been validated. Renal denervation for hypertension, another thing that may not turn out. So now let's talk about future. I already mentioned this in the present, but stroke thrombectomy. If we could train interventional radiologists, not just neurointerventional radiologists, to do this procedure, it could have a huge impact on society. Geniculate artery embolization for osteoarthritis of the knee, unproven, but who knows? Creation of AV fistulas for dialysis, not surgically, but percutaneously. There are some devices being developed and are out. And then here's a whole host of other things: percutaneous fempop bypass, cryoablation of the gallbladder instead of cholecystectomy, use of virtual reality in teaching, the use of artificial intelligence in radiology, and some other. So that is the conclusion of this part of the talk. And you could just remember this one thing: be a therapeutic skeptic, not a therapeutic nihilist. Some of the things I said sounded as if I completely disagree with their practice. And a few of the procedures, that's true, but mostly it's just be a skeptic and look at what we do and be selective in your choice of procedures with each patient as you move forward. So at this point, I would be happy to entertain any questions or comments from the audience.
Thanks, Jeff. This was an excellent talk. We have Dr. Angeline Iwak from Kenya. I think you met her during the trip to Kenyatta. Hey, Dr. Iwak, can you hear us?
Yes, I can hear you. And yes, hello, how are you? And thank you for the great talk. And thank you also for taking us through the road to IR, because in medicine, we know from the beginning we may have made many mistakes and even caused patient injuries. But with time, like you say, we should be a therapeutic skeptic. It's important for us to assess and also treat patients on case-to-case basis. Thank you very much for your talk. We are just starting our interventional radiology fellowship very soon. With support from, with support from Professor Dixon from University of North Carolina. They have been very supportive. They've been coming to teach our students, and they are really doing a lot, helping us, even coming with the skills labs. And they have made a big impact on our, especially the students, the residents who are in training and the final year residents. Most of them now want to do a bit of a IR fellowships. Thank you very much.
Cool. Thank you for saying that. And give you good luck in the future.
Thank you.
And Dr. Iwak, Dr. Eden will be also giving more lectures on interventional radiology. So I think,
hello?
Dr. Iwak, can you hear us?
Yes, I can hear you.
Yes, yes. I said Dr. Eden will be also giving more talks. So, you know, and I will send you the links so that, you know, the residents from Kenya can join. That's very nice. And we have a question for you,
Yes.
Jeff, for Jeff. This is from Aditi Chaurasia from All India Institute of Medical Sciences in Bhopal. The question is, why is sclerotherapy not a good option for AVMs? Is it because of increased chance of reformation? Thank you.
I don't mean to suggest it's not a good therapy. I did many of them right up until the end. It's just that there's a very narrow window between doing nothing and causing a complication. Because I used a lot of ethanol as my primary treatment, and it's hard to isolate it from the rest of the circulation, depending on where in the body you're treating. They're very frustrating. Nobody else in my group wanted to do them. I became kind of our regional expert. So I had quite a bit of experience, and I had some really nice cases, and I had some very frustrating cases, and I had some complications in dealing with them. And I had to see these patients many, many times, and it was rarely curative. But there are newer agents now, but you just have to be persistent. And my point only was that, as opposed to the example with draining an abscess, it's not a quick, easy, one and done with a high margin of safety procedure. It requires a significant amount of experience. Anybody starting it, I would recommend to have a mentor with a big backlog of experience to avoid some of the problems that can occur. Just one example would be when ethanol gets into the systemic circulation, if it can't be adequately isolated, either with mechanical means such as tourniquets in the extremities or occlusion balloons in the arteries or the veins, and it gets into the systemic circulation, it can cause some significant issues such as pulmonary constriction and right heart strain and things like that. And other agents have their foibles as well. So it's a challenging procedure with a narrow margin. But a lot of these patients don't have any other alternatives. So you just march through it and realize that in a few months, you may get a call again that the AVM or the venous malformation has recurred, and to go after it again. Now, there are AVMs in the brain that are different. I never treated those in certain parts of the body, but it was mostly in the trunk and the extremities, the ones I treated.
All right, that's very helpful. We have a WhatsApp message from Dr. Ivan Rukundo from Muhimbili in Tanzania. He had to leave early for a procedure. They have started their first interventional radiology fellowship program in Muhimbili, and he's asking if he can connect with you later after the presentation.
Of course.
Okay, all right, I'll let him know. And then we have a thank you from Dr. Helena Mashipia. Let's see if there are any other questions. Any other questions from the audience? Please feel to type in the Q&A box, and you can also send us an email later at contact@healthfortheworld.org. Jeff, I think this was just an excellent talk, and many of the countries where we are working, have either started an interventional radiology program or are about to start, as Dr. Iwak said, and I think this is a very good foundation for them. And many of the countries are planning in the next few years, so this would also help them with that vision. So we really appreciate you doing this for us. Let me see, I think.
My pleasure.
There's one more question, and that's actually from Dr. Iwak's daughter, Josephine Iwak. That's so nice. She said, what is your advice to persons interested in IR with your years of experience?
The things I would started with, for me, you want to innovate but validate. So just, that message, institute a good QA program from the beginning, and take care of yourself. So the physician wellness part of it is really important. And where you end up practicing is really important. You want to find a practice that you're comfortable with. I got very lucky. I didn't expect to be at the same place the whole time, but just the way things worked out and the autonomy I was allowed to build my department in the early days, and then the subsequent hiring of the staff. I got our first nurse in IR in like 1990, and then we built it, and it just turned out to be a fabulous cohesive group, and the leadership supported me. so that I could continue to grow. And it was actually fun to go to work. So you want to have a place that you enjoy, and your partners and your staff. And then those other two things. Physician wellness now is really important. I don't know how the practices are across the world, but as you know, Bhavya, the burnout rate and the stress rate among doctors in general, but including interventional and non-interventional radiologists, is high. The workload is significant. But IR is a very satisfying specialty. You do get some great results, and you feel a great connection to your patients.
Yeah, that's a great point, Jeff. And especially as you're saying, the burnout rate is pretty high, and with IR, there is direct patient communication and interaction. So certainly, and I know you have a great lecture on that also for the burnout. Then Josephine says thank you, and Dr. Aditi Chaurasia says, thanks a lot for answering my question, Dr. Jeff. We get a lot of sclerotherapy cases here because of the low cost of the procedure. But definitely, as you said, they require multiple sessions and have increased recurrence. Thank you.
Okay.
All right. I think those are the only questions. There is a comment from Mexico from Dr. Argelia Matos. Great talk and wise words. Thank you, Dr. Matos from Mexico. Thank you, Dr.
Thank you, and you're welcome.
Thank you. Thank you. All right. Any other comments or questions before we finish this talk? All right. So I think that should be it, Jeff. And if there are any more questions, I'm sure there will be, especially from Mohimbili. I'll send it to you by email. And for everyone else, we will be recording this lecture on YouTube and Health for the World Academy. So please feel free to check it out later and share with your colleagues who were not able to attend the lecture today.
Okay, thank you.
Thanks, Jeff.
Yeah.
You're welcome.
All right, have a good day. Really appreciate it. Thanks so much.
Okay, be safe, you guys.
Take care. Bye-bye.